So what a day! I think Juha, time for a couple questions, maybe.
Yeah, I think we definitely need a couple questions, but I know the alcohol is staring at us right out there. But let's field a couple questions. I definitely have one, but I'll give Dennis the first shot.
Okay, please.
That was a wonderful summary of the day. Following up on your last point, for those of us that are not experienced in working with the task force, you showed us the opening. Are there clear documented guidelines for how to approach them with maximum success, approach the whole process? Or is it simply writing the best paper that you can write?
That's a great question. I actually don't know that much about this process either. We've met with Doug a couple of times, and so there is a hierarchy of evidence. RCTs, well-performed RCTs being the highest, followed by observational data, followed by expert opinion. I think what we should do is write the best paper that we possibly can with the best data that we can, and synthesized in such a way to make a convincing argument. But beyond that, speaking with him and looking through the years, when Juha had mentioned this earlier, when colorectal cancer screening was first covered in 2001, there was no RCT data either for that. That was based on nested case control studies as well, and comparing colonoscopy to previous FOBT-based studies, intra-trial studies, comparing the effectiveness of those two. But based on that, colonoscopy got approved by the USPSTF. So, I do think that there's a large gray area too, where advocacy, having people in positions of power, authority, or visibility that care about this topic and will advocate for us, that is a big deal, and I think that makes a difference.
And just to follow up, is anyone aware of, if we go through this process, when we go through this process, and write the best paper we can write, let's imagine that the task force does not approve the recommendations.
Uh-huh.
Do they return to the authors a set of, sort of a critique, like you would get from a manuscript submission from the reviewers,
So there's
to say where they found the weaknesses that
I
maybe
believe,
would
yes, I believe they
inform
will.
us?
There's actually a multi-step process in this, and John was talking about how there's a firewall between the people who look at and synthesize the evidence, and the people who write the guidelines. And the USPSTF has a similar setup where there's a group or task force of experts who review the evidence and decide which topics have enough evidence to even move on to the full panel for review. And those are different groups of people.
And actually, he explained this to us. The other importance of submitting, even if we might be lacking data, is they do identify priorities in research. And so if there is a lack of data, they publish these priorities that actually go to Congress, and it is supposed to help guide funding. So he said that it was important. He really did tell us that he thought that this was within scope and that we were close. He said the one thing that would really push it over would be as if we had a randomized controlled trial, but that would actually take some time, but certainly feasible. The colon cancer one was approved on a randomized controlled study of sigmoidoscopy, and it was, I think, 500 patients in Scandinavia. So it wasn't this large RCT. So these are all feasible. I have a challenging question to both John and David, and it has to do with guidelines. So I've participated in the new grade guidelines through the AGA on pancreatic cysts. Very controversial. The technical review part is straightforward. My problem with the process actually is the guidelines side, because the society basically picks, quote, experts, and it's only like one expert from each field. You get a gastroenterologist, a surgeon, a primary care physician. I almost feel like that it's almost random in terms of what that person's bias is. And I think, for example, the pancreatic cyst guidelines could have been interpreted dramatically different depending on who was on that committee. Same thing with the recent intestinal metaplasia guidelines from the AGA. I think that the data could have been interpreted a little bit differently. And so, my thought is that we should have more. There aren't enough people on the guidelines side. It seems like that there needs to be broader representation and more representation of experts, even though they may be conflicted, to really represent the field, almost combine it with the grade plus a consensus group. Is there any thought to that? Because I really do think that they don't always represent the field adequately.
David, you want to go first?
Sure, why not? You're pointing up a limitation in the process that I think is valid. The guidelines are typically authored by either it's usually a very small group of people who are considered to be experts in the field. In the two societies that I've participated in, they are recommended by the leadership or the governing boards of the various societies, and it's sort of up to that governing board group to try to pick experts in the field, and then also balance those experts with diversity and all the other issues that are very important. So I think there's room for improvement there. John, do you have any comments?
And so you're showing your biases. So the main issue is that we're not the only ones who are looking at this. So there are external watchdog groups that evaluate guidelines. In particular, we've been hit, we meaning all the GI societies, ACG, ASGE, AGA, ASLD, because of the fact that we haven't been able to mitigate our conflict of interest well. We're not the only society, but this is something that's of heightened interest. And so if we don't approach this and really reduce or try to reduce the conflict of interest as much as possible, then all of these major, the payers, the policymakers at the level of the government are not going to take us seriously. And so we're already under the gun. So what you're suggesting is to try to increase the expertise by, and with that, unfortunately, comes conflict of interest. And so, this is always going to be a trade-off, but unless we do a better job of this, then, sure, it'll be guidance for a physician, but if the payers don't have to do it, if the policymakers, the government don't have to follow it, and don't do this, then the guideline itself can't be implemented from the payer side or from the policy side. And that's the problem we have here.
But they're really important, as I said, and we've really got to keep pushing forward.
If we have a question for Sam and Aki, that would be wonderful, but there's a hand back here, please.
Hi, thanks. To Dennis's point, if the Preventative Services Task Force does not approve the white paper moving forward, what about approaching other guideline bodies like the Multi-Society Task Force or NCCN? I know in the genetic testing world that payers listen to the NCCN guidelines to help guide their policy. Have we thought about those other bodies for support for this initiative?
Anybody want to answer that? Rob, you want to start with that one, or?
Yeah, I think I think we should go for kind of the highest level task force we can first, and then if it doesn't go, then at least we have a better sense of what's lacking, what they need, use that as a basis for further research. And certainly I think we should continue to advocate through multiple different societies and channels and mechanisms for what we think is right.
Aki, how do we get more patients involved? How do we get more patient advocacy groups, or how do we interact with them?
Oh, sorry. I'm sorry. Can you repeat the question?
I was just asking, what are your thoughts on how do we engage patient advocacy groups? What's the best way to approach you?
I think you guys give us the tools and we'll follow. Really, that's NCCN is great. They have stomach cancer patient guidelines. They have it for physicians and they have it for patients, and that's a tool that we give to patients. So we'll follow you guys.
And there are great models in the GI world now, and some of the ones you mentioned, pancreatic cancer networks and the colon cancer patient advocacy groups and survivor groups are just really, really well done.
Okay, one more question?
I think speaking to that topic, the U.S. Preventive Services Task Force is probably the highest bar that you have to meet. And there are steps that can be done before that, like provisional clinical opinions. I had the privilege of working on one of the ASCO provisional clinical opinions on diagnosis and screening in familial pancreas cancer. And again, I think that you have experts in the room that can actually agree on several points here, and that's the first step. Because one of the things about guidelines is that guidelines are there to guide us. They shouldn't be there to constrain us. So if Aki came to her doctor and said, my father died of gastric cancer and I have H. pylori, do I get an endoscopy? You know, part of the purview in our clinical care algorithm could be to say, you know what, I actually read this paper, and this paper says that you probably do need an endoscopy, so I'm going to order that endoscopy. We don't necessarily need the U.S. Preventive Services Task Force to decree that gastric cancer screening in the United States is now going to be approved. I think part of this is a piecemeal approach that actually involves both the physicians caring for the patients and the patients, and we advocate for what we think is right, and the data will follow.
Thank you. Maybe I'll take the prerogative of the moderator to ask the last question. Sam, do you want to make some final comments on what you've heard and from your perspective?
In a way, I agree. So even Hep B and C screening is recommended by the task force. The physicians, a lot of them are not ordering those tests. So, I mean, when I see my patient, if they hit 50, their time for colonoscopy. If they are Asian patients, I always say, at the same time, do an upper endoscopy. And I think we need to get our primary care docs to be informed so they recommend that. Because it's very easy to justify your upper endoscopy. Everybody has some stomach upset, right? I mean, so if you have some, peptic ulcers, heartburn symptoms, usually they get approved for the upper endoscopy. So, one time, actually, one of my patients came from Hong Kong and wanted to see me about hepatitis, and I said, well, you are fine, but you should get the upper endoscopy. And he actually had the upper endoscopy at Stanford, and then he flew to New York. And to the surprise of the endoscopist, biopsy showed an early stomach cancer. And so he actually went back to Hong Kong, had the surgery, and he's alive 15 years later, still going strong. So I think physician advocate, if they are informed about the risks, which I don't think a lot of primary care physicians are informed. If they are informed, a lot of them could be your advocate to get their patient screened. Without USPS, USPSTF basically is just, it become a covered service with no out-of-pocket charge, So I think if you don't hit that bar, you can still do a lot if the professional societies make some recommendation, and that get disseminated to the family physicians, internists, family medicine doctors in this, annual meetings or whatever. I think you could go very far with that.
Well, we've had it. David, you want to make a final comment?
Aki, if you come to New York with me tomorrow, I will do your endoscopy for you. Right? If you get me to stay here, I'll do it. Okay.
You can stay here. We'll do it here. Don't worry about that.
Well, what a fantastic day. Great panel. Big round of applause for our panel. Great.